So first going to the what is antimicrobial, we have to know some term. Chemotherapy. Chemotherapy is the drug for treatment of infection and malignancy. So chemotherapy combine both antimicrobial and cancer chemotherapy. Then chemotherapeutic agents, the drugs or agents that can act against the foreign component like microbials or malignancy. Then what is antimicrobial? The use of treating the infective agents. Infective agents is antimicrobial. And what is antibiotic? Those antimicrobial which is synthesized or originated from the microbes. They are antibiotics. So chemotherapy, chemotherapeutics agent, antimicrobial and antibiotics. Next, so all antibiotics are antimicrobial, but not all antimicrobials are antibiotics. Bacteriostatic are the agents that stop the growth of the bacteria, whereas bactericidal, they kills the bacteria. So statics means they stop the growth, whereas cidal, they kill the bacteria. Another term, PAE, post-antibiotic effect. It is occur when even in absence of the antimicrobial in the fluid, body fluid, they can have some effect on the antimicrobial. Then MIC, minimal inhibitory concentration. It is the concentration, minimum concentration of the drug that can inhibit the growth, whereas minimal bactericidal concentration, it is the minimal concentration which kills the bacteria up to 99.9%. So why it is important? For bactericidal, the minimum bacterial concentration minus minimal inhibitory concentration is less for bactericidal agent, whereas for the bacteriostatic, the difference is much more. So what is bactericidal and what is bacteriostatic agent? How we can classify it? We can classify it from the MIC and MBC. MBC means minimal concentration where 99% of the bacteria kills, whereas MIC where is the minimum concentration of the drug that inhibit the growth. The difference between MBC minus MIC, if it is small, it is considered, that agent considered bactericidal. If it is large, the agent, bacterial agent called bacteriostatic. Clear? So, what is bacteriostatic? Bactericidal, post-antibiotic effect, minimal inhibitory concentration, minimal bactericidal concentration, and what is the role of minimal bactericidal and minimal inhibitory concentration to say it is a bacteriostatic agent or it is a bactericidal agent. Two other name is prebiotic and probiotic. Prebiotics, they help to develop intestinal commensal and inhibit the growth of pathological component. Example is lactulose, lactylol, inulin. When this agent is live microbial, it is called probiotics. What is prebiotics then it helps to develop a growth of commensal, non-pathogenic bacteria in the intestine and suppress the pathogenic bacteria. If these agents are live microbes, then it is called probiotics, and when it is not a live microbe, it is called prebiotics. Prebiotics examples are lactulose, lactylol and inulin, whereas lactobacilli is example of probiotics. When we use prebiotics and probiotics, when we use long-term broad-spectrum antibiotic we use for any infection that can kill common cell, and that can lead to bacterial-induced diarrhea due to killing of disbalance of common cells and the pathogenic bacteria in the intestine. In that situation, we use probiotics and prebiotics. Prebiotics are lactulose, lactylol, whereas probiotics is the live organism like lactobacilli. So what are the different infection that can cause different site? First, brain. In brain, what is the common name? If there is an infection, meningitis, encephalitis. Meningitis and encephalitis is the common infection for brain and meninges. What are the organisms that can cause this? Pneumococcus, meningococcus, H. influenza, Listeria and Streptococcus agalacticus. These can cause meningitis and encephalitis. After brain, we go to the eye. Eye, there is a Staph aureus, Neisseria gonorrhoeae, Chlamydia trachomatis. After eye, sinusitis. Sinusitis can be caused by pneumococcus or H. influenzae. Then otitis media, commonly Streptococcus pneumonia or pneumococcus causes this otitis media. Then upper respiratory tract infection. Upper respiratory tract infection, which is the most common cause of upper respiratory tract infection? Most common cause means organism. Pneumococcus. It is a viral. Virus is the most common cause of upper respiratory tract infection. Why it is important? Most commonly when there is a cough and slight worm in this pharynges, we start antibiotic. Why it is important? Because as it is the most common cause is virus, it is not helpful for use of any antibiotic in this situation. Rather, it can causes resistance. So, other than virus, the common causes of upper respiratory tract is Streptococcus and H. influenza, followed by pneumonia or lower respiratory tract infection. We can divide it broader spectrum in 3 types, and one is most common in India, more prevalent is tuberculosis. Is very different treatment from the other. Other 2 is community acquired or hospital acquired. In community acquired, Streptococcus, pneumonia, H. influenzae and Staph aureus, whereas atypical are common in the hospital acquired cases. Mycoplasma, Chlamydia, Lignolia. These are commonly atypical pneumonia causes atypical pneumonia, commonly hospital acquired. Then gastritis can cause by H. pylori. We already discussed H. pylori regime. GIT পড়ানো হয়েছে? There are H. pylori regime for treatment of H. pylori. Then food poisoning. What are the common causes of food poisoning? Shigella, Salmonella, along with Campylobacter, Clostridium, Staph aureus. Staph aureus can also causes food poisoning, and the starting of the sign and symptom when it starts, symptom mostly within 6 hours. Then urinary tract infection, common cause of urinary tract infection, E. coli. Then other Enterobacteriaceae, sometimes Staphylococcus saprophyticus and Pseudomonas aeruginosa can be causes this urinary tract infection. Then skin infection, most common is Staph aureus, Streptococcus pyogenes and Pseudomonas aeruginosa. And last is sexually transmitted disease or STD, common cause of Chlamydia trachomatis, Neisseria gonorrhoeae. Then Treponema pallidum, that causes Treponema pallidum, syphilis, very good. Then Haemophilus ducresi. All these are sexually transmitted disease. From the head to toe, if you go, first meningitis and encephalitis, then eye, then otitis media, then you can go to the upper respiratory tract, lower respiratory tract, gastritis, food poisoning, followed by urinary tract infections, skin infection and STD. And we have to remember common causes of this type of, supposedly E. coli very rarely or never causes any LRTI. Similarly, you cannot say Streptococcus pneumonia causes UTI. Why it is important? Because sometimes for empirical therapy, before coming report for the culture, we have to start some antibiotic. Depending upon the site of infection involved, we can choose some. We can have to choose this antibiotic and its regime. So for that, we have to first, if there is an infection, where it is located, what are the common causative organism in this situation. After basis of that, we can start antibiotic. Similarly, we mostly have two types, gram positive and gram negative. Gram positive peptidoglycans are easily accessible, whereas though it is a thin wall for gram negative bacteria, but it is not easily accessible. It is like that for gram positive, it is easily accessible, but in case of gram negative, it is sandwiched between these two polysaccharides, proteins and phospholipids, these peptidoglycans. So if we go for the history, in ancient history, Chenopodium is used for intestinal worms, moldy card for the boils, for leprosy, chalmugra oils. Similarly, mercury is used for syphilis and cinchona bark used for malaria. So, but the development primarily occurred in the 19th century. So first, Louis Pasteur discovered or developed an idea, invented the phenomenon of antibiotics in 1877. 1906, Paul Ehrlich, who is another term chemotherapy, is coined, and Paul Ehrlich is important for MCQ because he is the mentioned as a father of chemotherapy. Father of chemotherapy is Paul Ehrlich. Then Domac in 1935 first developed prontosil and sulfonamide during the World War II. After that, Fleming, Chain, Flooding, they developed penicillin. And Waxman from the actinomyces developed streptomycin. So this is the development of different antibiotics from the 1877 till date. So first sulfonamide, followed by penicillin, then aminoglycoside, cephalosporin, chloramphenicol, up to 2003, lipopeptides are developed. So first you have to remember, first antibiotic developed it is not the penicillin but the sulfonamides. Not the penicillin but the sulfonamide is the first antibiotic for clinical use, followed by penicillin. After that, aminoglycoside, cephalosporin, chloramphenicol. And another thing is that rifampicin. Rifampicin is used in which drug? Tuberculosis. It is developed in 1957. So that is a landmark for treatment of tuberculosis. So first is in 1935 sulfonamide starts, then breakthrough 41. It is also during that World War, penicillin, and after World War, the important stage is 1957 when rifampicin, which is the main cornerstone of the treatment of tuberculosis, has developed. We can classify antimicrobials in basis of either chemical structure. It is very difficult to remember chemical structure and their name, but more importantly by the mechanism of action, organism type, in which type of organism they act, spectrum of activity. It is important clinically. The which spectrum? That means gram positive, gram negative, difficult, and Mycobacterium tuberculosis. Then we can divide it depending upon the cidal or static. Cidal means they kills the bacteria. Static means they prevent the growth. And lastly, the origin of the antimicrobials. You have to remember few of these polypeptides: polymyxin, bacitracin, colistin. Colistin nowadays very regularly used in ICU setup. Poly-in antibiotic, nystatin, amphotericin B, hamycin, polypeptide and poly-N antibiotic. Then lincosamide, clindamycin. Clindamycin commonly used anaerobic bacteria. Glycopeptides like vancomycin, teicoplanin. Where it is used? They are used in MRSA, methicillin resistant Streptococcus aureus, vancomycin, teicoplanin can be used. Oxyzolidine, linezolid. Linezolid is a very narrow spectrum drug, commonly acts in the skin, especially Staph aureus. But nowadays it is clinically very important because it is a reserved drug for the tuberculosis. Any drug which is reserved drug for the tuberculosis, you have to think not to use at the first line in other cases. Clear? Because if you prescribe it rampantly, their development of resistance against that drug can be very easily developed, and then it cannot be used against the tuberculosis also. Then rifampicin, gaseofalmin, diaminopyranamide, trimethoprim, pyrimethamine, quinolones, fluoroquinolones like ciprofloxacin, fluoroquinolones like beta-lactam. Beta-lactam is penicillin, cephalosporin, monobactam and carbapenems. You have to remember these four beta-lactam. Beta-lactam, penicillin, cephalosporin, monobactam and carbapenem is the composed beta-lactam group of antibiotics. Aminoglycosides, streptomycin, gentamicin, they commonly, beta-lactam primarily cover the gram-positive coccus, whereas gram-negative bacilli is covered by the aminoglycoside. Tetracycline is one of the most used broad-spectrum antibiotic. So you have to remember the broad-spectrum antibiotic is tetracycline, whereas narrow-spectrum antibiotic, which are the commonly used narrow-spectrum antibiotic, is penicillin. They act on gram-positive coccus. Gram-negative bacilli are inhibited or killed by aminoglycoside. So these are narrow-spectrum. Broad-spectrum antibiotic is one name of broad-spectrum antibiotic, tetracycline. Then sulfonamides, macrolide like erythromycin, clarithromycin, they also cover more gram-negative bacilli. Azoles, fluconazole, cotrimazole, they are antifungal drugs. Azoles are antifungal drugs, but not metronidazole. Metronidazole used in amoebiasis, amoebiasis, and another one is if there is an anaerobic bacteria, then we can use metronidazole, nitroimidazole. Why it is important? That fluconazole, cotrimazole, all ends with azoles, they are antifungal. Metronidazole also ends with zole, but it is not an antifungal. Metronidazole used in amoebiasis and anaerobic infection. Other anaerobic infection drug used in anaerobic infection is clindamycin. You have to remember this. Gram positive is beta-lactam, primarily penicillin, cephalosporin. Gram negative, only gram negative inhibited by aminoglycoside. Broad spectrum is tetracycline. Then azoles are fluconazole, cotrimazole are antifungal. Metronidazole is anti-amoebic. It can be also be used in anaerobic bacteria. Which can be used in anaerobic bacteria? Clindamycin. Clear? Then nicotinic acid derivatives, isoniazide, pyrazinamide and ethionamide. Where it is used? Antitubercular drugs. These are antitubercular drugs. Another question for antitubercular, name a injectable antitubercular. Injection দেয় এগুলো কি ওরালি না ইনজেকশন টিউবারকুলোসিসে দেয়? ওরালি মোস্টলি। একটা ইনজেক্টেবল স্ট্রেপ্টোমাইসিন, ঠিক আছে? আর all these isoniazide, pyrazinamide and rifampicin are bactericidal. So static is only ethambutol. Ethambutol is the only first line antitubercular drug which is bacteriostatic. Similarly, most of the first line are nicotinic acid derivative like isoniazide, pyrazinamide, ethambutol. Which one is not? Rifampicin. Rifampicin among the all first line anti-tubercular drug which is not an nicotinic acid derivatives. Nitrobenzene, chloramphenicol. Chloramphenicol, which is the important thing of chloramphenicol. Chloramphenicol, when it come out, it is a very good drug against Salmonella typhi, for typhoid. But there are two very important side effects which restrict their use. Number one, idiosyncratic type of bone marrow depression. Idiosyncratic and dose dependent. There are two types of side effect. Dose dependent means in lower dose this side effect is not happen. In higher dose, only in higher dose it manifests this type of side effect. Whereas in idiosyncratic, depending upon the genetic of this patient, it can causes bone marrow depression even in very small dose in some patient, whereas in higher dose, even in higher dose, they cannot produce, they are not producing bone marrow depression in some patient. So idiosyncratic type of bone marrow depression and gray baby syndrome. Gray baby syndrome, these two are the common side effect of chloramphenicol which restrict their use against Salmonella typhi, especially in children. Nitrofurantoin derivative, nitrofurantoin, these are used in urinary tract infection. So these are classic. If depending upon the organism, what are the different organisms? Bacteria, virus, protozoa, then helminth and fungus. So antibacterial, antiviral, antifungal, antiprotozoal and helminth. It is not the anti-helminth, it is ant-helminth. A-N-T-helminth. So all are anti except the helminth, it is ant-helminth. Clear? Then depending upon the source, from which source this antibiotic develops. From the fungus, penicillin, cephalosporin, these are penicillin and cephalosporin is broad spectrum. এতক্ষণ বলার পর narrow spectrum acts on gram positive coccus. Broad spectrum এর নাম কি? tetracycline. Graciofulvin is a antifungal. Graciofulvin is a antifungal. So not only azoles, graciofulvin, amphotericin B, all are the antifungals. Then from the bacteria itself, polymyxin B, colistin and bacitracin, these are developed from the bacteria itself. They are antibiotics or antimicrobials. Which is difference between antimicrobial and antibiotics? Antibiotics is the antimicrobial which is developed from live organism. These are antibiotics. whereas antimicrobials can be from the like penicillin, cephalosporin, or it can be developed in the laboratory also. Similarly, from the actinomyces, most commonly these antibiotics developed from the actinomyces, aminoglycoside, tetracycline, chloramphenicol and macrolide. All these, another important thing, all these four are protein synthesis inhibitor. Protein synthesis inhibitors. Next spectrum, narrow spectrum ki penicillin G. Then penicillin G kon group hai? Beta-lactam, gram positive, cocci against streptomycin is the aminoglycoside. It can be used as a anti-tubercular injectable drug, and it acts against primarily gram-negative bacilli, and they have action against Mycobacterium tuberculosis. These are all injectable drugs. Okay, antibiotic. Erythromycin is also protein synthesis inhibitor. These are narrow spectrum. Broad spectrum is tetracycline and chloramphenicol. Tetracycline and chloramphenicol is the broad spectrum. Then extended spectrum. So we take some side chain of this penicillin to develop their spectrum as well as resistance against the acid. So penicillin cannot be given orally, but ampicillin, amoxicillin can given orally. So nowadays you will see we use ampicillin, amoxicillin, but very rarely penicillin. Why? What is the advantages of penicillin and amoxicillin over ampicillin, amoxicillin over penicillin? Number one, they can be orally given as they are acid resistant. Number two, they have a broader spectrum or extended spectrum than the penicillin. Bacteriostatic drugs are sulfonamide, tetracycline, chloramphenicol, macrolide, ethambutol. Ethambutol used where? Anti-tubercular drug. And nitrofurantoin. Nitrofurantoin is a urinary antiseptic. Bactericidal is cotrimoxazole, penicillin, cephalosporin, aminoglycoside, vancomycin, fluoroquinolones, INH, rifampicin, pyrazinamide. So which anti-tubercular first line drug is bacteriostatic? Ethambutol. Which one are bactericidal? All three: INH, rifampicin, pyrazinamide. And metronidazole, where it is used? MBBS and anaerobic infection. So bacteriostatic and bactericidal. So spectrum, if we go for the spectrum, for penicillin it is primarily cover gram positive, and few of them can cover chlamydia and gram negative bacilli, whereas cephalosporin, sulfonamide, quinolones, carbapenem, they restricted gram positive and gram negative few. Streptomycin restricted between gram negative and Mycobacterium tuberculosis. Tetracycline is a broad spectrum. They doesn't cover mycobacteria, but other like gram positive, gram negative, chlamydia, rickettsia is covered by tetracycline. So the broadest spectrum antibiotic is tetracycline. They cover gram positive, gram negative, chlamydia as well as rickettsia. Similarly, if we go for isoniazide, it is very narrow spectrum, only cover the Mycobacterium tuberculosis. Polymyxin only gram negative bacteria, vancomycin only gram positive bacteria. Clear? So difference between narrow spectrum and broad spectrum. Gram positive, gram negative, most of the drug can cover like beta-lactam, some gram positive, few gram negative. But when like tetracycline, not only gram positive and gram negative, they also cover chlamydia, rickettsia. Very rarely other drugs can cover that. Clear? Similarly, few drugs are there like isoniazid, polymyxin B and vancomycin. They are restricted only one group. They are very narrow spectrum. So, the most important classification to remember different antibiotics is through the mechanism of action. First, cell wall synthesis inhibitor, beta-lactams, vancomycin and cycloserine. Now you tell me what are the beta-lactams? Beta-lactam KK, penicillin, cephalosporin, carbapenem, monobactam. Clear? So they are all cell wall synthesis inhibitor along with vancomycin. Vancomycin is not a beta-lactam but a cell wall inhibitor. And last one is cycloserine. Cell wall inhibitor. Next one is cell membrane leakage. Cell membrane leakage. So action on cell wall is beta-lactam, vancomycin. Cell wall, action on cell wall is polypeptide and polyene. These are acting on cell membrane, not cell wall. Clear? Third one is folate synthesis inhibitor. Folate synthesis inhibitor. Folate কিসের জন্য লাগে? DNA synthesis এর জন্য. So folate synthesis inhibitors are sulfonamide, pyrimethamine, cotrimoxazole, PSA and ethambutol. Ethambutol কোথায় লাগে? Use হয় tuberculosis এ. So these are folate synthesis inhibitor. So cell wall, cell membrane, folate synthesis inhibitor. Then DNA তে চলে এলাম. DNA gyrase inhibitor or topoisomerase inhibitors. DNA gyrase inhibitor or topoisomerase inhibitor is fluoroquinolones. Ciprofloxacin, catifloxacin, these are DNA gyrase inhibitor. Then DNA এর পরে কি? RNA. RNA থেকে rifampicin. Rifampicin inhibits RNA synthesis or RNA polymerase inhibitor. And last one তাহলে কি হলো? Cell wall, cell membrane, folate, folate এর পরে DNA gyrase, DNA gyrase এর পর RNA polymerase, RNA এর পর কি হয়? Protein. Then protein synthesis inhibitor. Protein synthesis inhibitor কে আছে? Aminoglycoside, tetracycline, chloramphenicol, macrolide, clindamycin and linezolid. Clear? এই ক্লাসিফিকেশনটা মনে রাখতে হবে. You have to remember this. Cell wall, cell membrane, folate, folate এর পরে DNA gyrase, DNA এর পরে RNA polymerase, RNA polymerase এর পরে protein synthesis. Then তাহলে cell wall inhibitors are beta-lactam, vancomycin, cycloserine. Cell membrane, polyenes and polypeptides, cell membrane. Then folate synthesis inhibitors like sulfonamide, pyrimethamine, cotrimoxazole, PSA, PAS and ethambutol. Then DNA gyrase are fluoroquinolones. RNA polymerase are rifampicin. কোথায় ইউজ হয়? First line antitubercular, first antitubercular to develop in 1957. Then protein synthesis inhibitor. কে? এগুলো মুখস্থ করতে হবে. এগুলো মানে একদম বলতেই হবে. Protein synthesis inhibitor, broad spectrum tetracycline, broad spectrum chloramphenicol, then narrow spectrum, আবার penicillin তো cell wall, aminoglycoside, aminoglycoside এর পরে macrolide, other than that linezolid and clindamycin. Clindamycin কোথায় ইউজ হয়? অ্যানারোবিক ব্যাকটেরিয়া। আর কোন অ্যানারোবিক ড্রাগ অ্যানারোবিক ব্যাকটেরিয়া ইউজ হয়? মেট্রোনিডাজল। মেট্রোনিডাজলের আরেকটা ইউজ কি? অ্যামিবিয়াসিস। ইউ হ্যাভ টু রিমেম্বার লাইক দ্যাট। সেল ওয়াল, সেল মেমব্রেন, ফোলিয়েট সিনথেসিস ইনহিবিটর, DNA gyrase, RNA polymerase, protein synthesis inhibitor, and drugs which one comes under that. এটা পুরোটা মনে রাখতে হবে। ক্লিয়ার? So why all these antibacterial agents only attacks the bacteria itself, not the human body. There should be a side effect. So first one is human does not possess cell wall. Number two, cell membrane are different. Cell membrane are different from the bacteria. Bacteria contains hyponoids in place of sterols. Human cells take preformed folate. They doesn't develop folate. They doesn't require folate synthesis. Folate synthesis inhibitors kara sulfonamide, pyrimethamine, cotrimoxazole, তারপরে EAS and ethambutol. So dihydrofolate reductase enzymes are different for bacteria and human beings. Topoisomerase 2 are different, মানে DNA gyrase যেটা topoisomerase 2 are different for bacteria. This DNA gyrase or topoisomerase 4. DNA dependent RNA polymerase are characteristically different from the bacterial RNA polymerase, and human body has a ribosome 60S instead of 50S, which is present in the bacteria, 40S instead of 30S. Clear এই পর্যন্ত? আগের গুলোর সাথে কোরিলেট করার জন্য সেল ওয়াল ইজ ডিফারেন্ট। সেল ওয়ালের উপর কে কে কাজ করছে? সেল ওয়ালে কাজ করে কে কে? beta-lactam কি কে? পেনিসিলিন, সেফালোস্পোরিন, মনোব্যাকটাম, কার্বাপেনামস। ঠিক আছে, এর সাথে কি কি থাকবে? এগুলো হচ্ছে beta-lactam। beta-lactam বললে চারটে মনে করতে হবে। কি কি? পেনিসিলিন, cephalosporin, monoBactam, carbapenem. All these are beta-lactam. The non-beta-lactam antibiotic which has a action on the cell wall, vancomycin, cycloserine. এইভাবে মনে রাখতে হবে। vancomycin and cycloserine is the non-beta-lactam cell wall inhibitor. Clear? So beta-lactam breaks that bond. Not only beta-lactam, most of this cell wall will details mechanism of this mechanism will be in detail in the penicillin group of them. Similarly, protein synthesis inhibitor, aminoglycoside binds with the 30S array. Similarly, tetracycline binds the interface of 30 and 50, whereas chloramphenicol, macrolide, erythromycin, all these are binds with the 50S. DNA gyrase কে করে? মনে রাখতে হবে DNA gyrase fluoroquinolones. rifampicin কি করে? RNA polymerase. ভেরি গুড। তাহলে প্রোটিন সিনথেসিস ইনহিবিটর কে? একটা অ্যামাইনোগ্লাইকোসাইড, হ্যাঁ, ম্যাক্রোলাইড, লিনোজোলাইড। আগে প্রথম চারটে বলে দিতে হবে, দুটো ব্রড স্পেকট্রাম, দুটো ন্যারো স্পেকট্রাম। কি কি? ব্রড স্পেকট্রাম কি আছে? আরেকটা টেট্রাসাইক্লিন এন্ড ক্লোরামফেনিকল। দেন ন্যারো স্পেকট্রাম protein synthesis inhibitor is aminoglycoside, then macrolide, তারপরে লিনোজোলিড। লিনোজোলিড কোথায় ইউজ হয়? where we can use linozolid? Staph aureus and it is a second line drug for reserve drug for tuberculosis. So PABA, dihydrofoliate synthesis, dihydroreductase, then tetrahydrofolic acid, from that DNA RNA unwinding এর জন্য it requires DNA gyrase, head separation, topoisomerase 4, then RNA polymerase, and from the mRNA through ribosome 50-30 protein synthesis. So for first sulfonamide, they act on PABA analogs and inhibitor of dihydrofolate synthetase. For reductase, it is trimethoprim and pyrimethamine. For reductase. Quinolones inhibit DNA gyrase and topoisomerase 4. Rifampicin inhibits RNA polymerase. Then chloramphenicol acts on 50S aminoglycoside and 30S and tetracycline interface of 30S and 50S. Clear? If you remember this, the basic mechanism of action of common antimicrobial will cover. So for sulfonamide, dihydrofolic acid synthetase inhibitor. Reductase inhibitor is trimethoprim and pyrimethamine. Then quinolones inhibit topoisomerase 4 along with DNA gyrase. RNA polymerase inhibited by rifampicin and the protein synthesis inhibitor 50S is chloramphenicol macrolide, aminoglycoside tetracycline is 30S. ঠিক আছে এই পর্যন্ত? এগুলো আগে যেগুলো আমরা পড়েছিলাম সেগুলো স্যার নাম্বারিং করে দিলে এটা চলে আসবে। সেল ওয়াল সিনথেসিস, পেনিসিলিন, সেফালোস্পোরিন, কার্বোপেনেম, মোনোব্যাক্টাম, ভ্যানকোমাইসিন, সেল মেমব্রেন পলিমিক্সিন, 30S tetracycline aminoglycoside, 50S macrolide, clindamycin, linezolid, chloramphenicol, streptogerminase, RNA polymerase, rifampicin, quinolones, DNA gyrase. আর ফোলিয়েট সিনথেসিস ইনহিবিটর হচ্ছে সালফোনামাইড, রিডাক্টেজ ইনহিবিটর ইজ ট্রাইমিথোপ্রিন। আর একটু পড়াবো না এই পর্যন্ত থাক আজকে? হ্যাঁ আর একটু পড়াই। Antibiotic can be dose dependent and time dependent. If it is dose dependent, then we can give this drug once or twice a day. And if only for few minutes, if it goes beyond the concentration, they can have the dose inhibit the antimicrobial. Whereas there are some drugs that requires IV infusion or 3 to 4 times a day. Though its half-life is long, we have to give this infusion because it is a time dependent. Time dependent means it requires the high level of concentration at least more than the minimal inhibitory concentration or minimal bactericidal concentration more than that throughout the time. So it is a time dependent. And if aminoglycoside, fluoroquinolones, metronidazole or amphotericin B, their peak if it goes once above the required concentration, that is dose is more than the MBC or MIC, they have a post-antibiotic effect. For that, they doesn't require the throughout the time above this concentration. Whereas in time dependence, you have to give infusion drugs like beta-lactam, glycopeptide, macrolide, tetracycline and vancomycin. These are the time dependent. Post-antibiotic effects means even in absence of the drug in critical concentration, they have an effect against the antimicrobial agent. And which drug has this? Example, which drug has this post-antibiotic effect? এক্ষুনি বললাম aminoglycoside, fluoroquinolones, metronidazole, amphotericin B. Which drugs have post-antibiotic effect? They are dose dependent, not time dependent. Then mechanism of resistance. So some antibiotic cannot kill against the number A bacteria but has their effect against the number B. So that resistance may be intrinsic. Intrinsic means from the developmental phase, there has no effect on that. Supposedly, aminoglycoside never has a coverage against gram-positive bacteria, or penicillin G never has a coverage against chlamydia rickettsia. Clear? So it is a intrinsic. Another one is acquired. Acquired can be two types. One is mutation, small genetic change, or transferred. A resistant genetic portion which develops the resistance is transferred to the bacteria. It can be by three types. Transduction, transformation, and conjugation. এগুলো তো পড়ানো হয়েছিল, এগুলো পড়ানো আছে তো। For conjugation from which part? Plasmid. Plasmid মনে আছে তো? Plasmid কি? DNA which is outside the nucleolus. Similarly, transduction কিসের দিয়ে হবে? Bacteriophage দিয়ে. Bacteriophage is a virus which takes this resistance DNA and pour into the bacteria itself. As transformation, অনেক কটা already killed bacteria, from that this genetic material which develops resistance go into the live organism and they develop resistance against it. So which one is important clinically? Inheritance or acquired? Which one is clinically important? You know this drug is not effective against this bacteria. So it is clinically insignificant because you know it. But you know drug A can have some effective against bacteria X. You use this drug, but it is develop resistance, so their action is not proper. Patient deteriorates. So acquired types of resistance is important for clinical setup. ঠিক আছে? এগুলো পড়ানো হয়েছে। আচ্ছা, এইটা ট্রান্সফরমেশন, transduction and conjugation. Conjugation from the plasmid, transduction from the bacteriophage, and from the already killed bacteria, transformation. Clear? It is the and other part acquired হচ্ছে mutation করে. This is the mechanism of resistance. Now, how this resistance develop? There may be some enzyme that can destroy the antibiotic itself. Penicillinase, beta-lactamase, they break down the beta-lactam antibiotic chemically. Similarly, ribosome modification. So, previously sensitive ribosome is not sensitive anymore. Ribosome modification, protein modification, mutation of target protein. For MRSA, the binding protein of the penicillin, MRSA, they altered their structure. Metabolic resistance, they have an alternative pathway to develop folate and efflux. Antibiotic is not able to penetrate the bacteria itself. So one is blocking, one is inhibiting the antibiotic, third one is efflux and alterate the target. There are primarily these 4 or 5 mechanisms. Beta-lactam antibiotic develops resistance due to hydrolysis of the beta-lactam ring and mutation of PBP, penicillin binding protein. Similarly, tetracycline efflux from the cell. Tetracycline is the broad spectrum protein synthesis inhibitor. Aminoglycoside inactive the enzymes. Sulfonamides alternate pathway. Pseudoquinolone mutation of the DNA gyrase. Chloramphenicol reduce uptake of the antibiotic up to the cell, and macrolide RNA methylation and DNA drug efflux. These are the common mechanism of action of development of resistance. ঠিক আছে, থাক তাহলে আজকে এই পর্যন্ত। কি হলো তাহলে? অ্যান্টিবায়োটিক আর অ্যান্টিমাইক্রোবিয়ালের পার্থক্য কি? কেমোথেরাপি আর অ্যান্টিবায়োটিকের মধ্যে কি পার্থক্য? কেমোথেরাপি মিন্স অ্যান্টিবায়োটিক প্লাস ক্যান্সার কেমোথেরাপি। তারপরে হচ্ছে ক্লাসিফিকেশন অফ দ্য অ্যান্টিমাইক্রোবিয়াল, যেটা মনে রাখতেই হবে আর কি, সেটা হচ্ছে থ্রু দ্য মেকানিজম অফ অ্যাকশন। কি? সেল ওয়াল, সেল মেমব্রেন, ফোলেট, ডিএনএ, আরএনএ, প্রোটিন, এবং তার আন্ডারে কোন কোন অ্যান্টিবায়োটিক আসছে, এটা কিন্তু মনে রাখতেই হবে ওই স্লাইডে। তারপরে হচ্ছে রেজিস্ট্যান্স। রেজিস্ট্যান্সের মধ্যে অ্যাকোয়ার্ড রেজিস্ট্যান্স আর ইনহেরিট। হুইচ ওয়ান ইজ ইম্পর্টেন্ট ফর এক্সপ্লেন হোয়াই অ্যাকোয়ার্ড ইজ মোর ইম্পর্টেন্ট? অ্যাকোয়ার্ডের মধ্যে কি আছে? কনজুগেশন, ট্রান্সফরমেশন, ট্রান্সডাকশন। ট্রান্সডাকশন মানে ব্যাকটেরিওফাজ, কনজুগেশন মানে প্লাজমিড, তাহলে বাকি পড়ে রইল যেটা ট্রান্সফরমেশন ইজ দ্য অলরেডি ডেড ব্যাকটেরিয়া থেকে যেটা আছে। ঠিক আছে, তারপরে যে মেকানিজম অফ ইফ্লাক্স, টার্গেট মলিকুল চেঞ্জেস, অল্টারনেটিভ পাথওয়ে, and which drug develops resistance in which mechanism. আর হচ্ছে কোনটা ন্যারো স্পেকট্রাম, কোনটা ব্রড স্পেকট্রাম। ব্রড স্পেকট্রাম কে? টেট্রাসাইক্লিন আর ক্লোরামফেনিকল। ন্যারো স্পেকট্রাম পেনিসিলিন, অ্যামাইনো অ্যাসিড। ভেরি গুড।